Everyone, welcome back to today's video, and in this video we will be discussing about sensitivity and specificity of a diagnostic test. So the first point to remember is that sensitivity as well as specificity and the likelihood ratio does not depend on prevalence or any other external factor. They reflect the intrinsic diagnostic value of the test. But on the other hand, the positive and the negative predictive values depend on prevalence. So how prevalent the disease is in a population. So that changes positive and negative predictive values, but not sensitivity, specificity or the likelihood ratios. So coming to sensitivity, sensitivity of the test means that of all the patients who are truly diseased, this whole part, how many will test positive? This part. So this reflects that how good a test is in catching a disease. So how will you measure it? How will you calculate it? We will take the disease population, and out of those, how many are true positive? That means how many are tested positive. So you look down at the disease present column, this column. So you take true positives divided by whole of this disease column. So coming to an example, imagine a screening test for HIV with 99% sensitivity. So what does that mean? If there are 100 people with HIV, the test will correctly pick 99 of them, but it will miss one person because it is 99% sensitive. If it would have 100% sensitive, it would have picked all the 100 people, but that almost never happens. Flip side is that test will also label some people as HIV positive when they don't have HIV. So it will catch all the HIV people, but it will label some people as HIV positive when they are actually disease negative. So that is the flip side of a sensitive test. Another way of saying is a test is positive in 99% of the people who do have a disease. So these are true positives. So that is what we mean by sensitivity. Coming to specificity, specificity of the test means that of all the healthy patients, this group, how many patients will test negative? So in other words, how good a test is in ruling out a disease. So we do a screening test and we will have lot of patients. Some actually have a disease and some of them don't have a disease. So how do we know that some people who actually don't have a disease and they are falsely positive, how do we rule them out? We rule them out using the specific test. We will discuss that later. So the formula is that you take the disease negative patients and you take true negative patient and divide these values. So specificity looks down at the disease absent column. You will look at this particular column and you take true negative divided by whole of this column, that is false positive plus true negatives. So that is the specificity of the disease. Now to give you an example, imagine a confirmatory test for HIV with 99% specificity. So 100 people, you take 100 people and conduct a test in them. These 100 people are healthy people. So this 99% specific test will correctly rule out HIV in 99 people. That is what we mean by 99% specificity. But it will falsely diagnose one person as HIV negative when they actually have the disease. So we have a false negative here. So that is what we mean by a specific test. In other words, the test is negative in 99% of the people who do not have the disease. So these are healthy people. True negatives. So that is what we mean by specificity. So how do we implement these tests, specific test and sensitive test in a clinical scenario or in the real world? First we do a sensitive test for screening. We do screening by sensitive test. It will catch all the people with the disease, but it will wrongly diagnose some healthy people as diseased. Then what we will do? We will do a specific test for confirmation. So what this specific test will do? It will rule out the disease in healthy people. It will catch all the healthy persons who were wrongly diagnosed with the disease using the screening test for the more sensitive test. Now there is a question that comes in the exam, that what are the characteristics of a ideal screening test. So some people mark it as high sensitivity, that is what we have discussed here, but they are asking for an ideal screening test. Ideal means it will have high sensitivity and high specificity, but in real world there is always a trade-off between sensitivity and specificity. So if we have to choose, we will choose a highly sensitive test. But if the question comes about the characteristic of a ideal screening test, you will mark as high sensitivity and high specificity. Okay, so let's discuss sensitivity and specificity with one diabetes example, how it works in the real world. So we will take some values in normal people, some blood glucose values in normal people and some blood glucose value in diabetic patients. So if you see, the average values here are much less as compared to average values here. Here we have higher values, 101, 122. Here we have lower values, 87, 92. So it is pretty obvious that in normal people, the blood glucose levels will be lower. But if you see closely, there is some overlap. If you see, we have 99 here, we have 99 here, so there is an overlap. And some values in diabetic patients are lower, 99. Here, normal person has 105. So what I mean to say here is that in real world, some diabetic patients can have a normal values of blood glucose levels than normal people. So if you see here, if you plot it graphically, if you plot it statistically, then we will get a graph something like this. So these are all normal people. These are all diabetic people. But if you see, some diabetic people, this part has lower blood glucose value than normal people, this part, right? And there is an overlap, some overlap, and some normal people have blood glucose values higher than diabetic patients. So I hope this is clear. But just a hypothesis, if our graphs would have looked something like this, that normal people are here and diabetic people are here, there is no overlap, and all the diabetics have higher blood glucose value than normal people, then it would have been very easy. We would take a threshold here, and whoever tests positive will be considered as diabetic, and whoever tests negative will be considered non-diabetic. I am talking about the threshold of the test. Suppose you say that this is 70 milligram percent or 70 milligram per deciliter, then we would have taken this threshold and the life would be easy. But this never happens. Actual graph looks something like this, right? So let's discuss this. So suppose our threshold is here, our cutoff value is here. We have taken a certain cutoff value of a blood glucose level. Then everybody who is more than this cutoff will be considered positive for diabetes, and everybody who is negative, who has a lower blood glucose level than this particular threshold will be considered negative for diabetes. So what will happen due to this overlap? Some diabetics, this group, some diabetics will have a lower blood glucose level. So these are false negative. What do we mean by false negative? That although the test is showing that they are negative for diabetes, but they actually are diabetic, right? So this particular part I am talking about. So we have taken a cutoff here, so they have a negative test, this part is negative, but they are actually diabetics because they are coming under this graph, right? So that is what we mean by false negatives. Similarly, the patients who have blood glucose value greater than this cutoff and actually have diabetes are considered true positive, and people who have blood glucose value greater than this cutoff but comes under this graph, that is normal people, are false positives, and similarly we have true negatives. So this graph is very important for further discussion. So please stop the video if you want and just look at this graph. So anybody who has blood glucose level above this are positives. Anybody below this cutoff are negatives. So negative, but some of them are true negatives. who truly don't have diabetes. Some of them are true positives who truly have diabetes. Similarly, some people are false negative and some people are false positives. Now the question is, we have taken the cutoff here before. This was our threshold. But if I decrease this threshold, what will happen? I will have all the positives, all the diabetics as positive, right? So I will catch more true positives. So what does that mean? What is this formula? This formula is sensitivity. Sensitivity, right? So what is sensitivity? That how many true positives I can catch. So if I lower this threshold, previously my threshold or cutoff was here. If I lowered this threshold, previously I was able to catch only these much of true positives. Now I am able to catch all the true positives. So lowering the threshold increases the sensitivity. What is sensitivity? True positives. So I am now catching more true positives. So that is why my sensitivity will increase. But I will have decrease in specificity. Increase in false positives. So stop this video and just think which are false positive in this particular graphs. So these are false positives. So we have discussed before that if we increase the sensitivity of the test, if we take a more sensitive test, the ratio of false positive will also increase. So these are false positives because the test is positive. After this value, the test is positive, but these are normal people. So this is false positive. So if you see my previous threshold, I am not including these people in my positive test. But if I decrease my threshold, although I am catching more true positives, but I am also catching some false positive. My test is positive for some normal people as well. So that is why lowering the threshold increases the sensitivity, catching more true positives, decreases specificity, this part, but increases false positives, this part. I hope this is clear. Now coming to increasing the threshold. Similarly, if I increase the threshold, what will happen? Now all these patients are positive. All these patients are positive, all these patients are negative. So I am now able to include all my true negatives. If the test is negative, then that means patient is truly negative. He doesn't have a disease or she doesn't have a disease. So my true negatives will increase if I increase my threshold. So increasing the threshold will increase the specificity because I am able to catch all the true negatives now. Previously, I was able to catch only these much of true negatives. So increasing the threshold, increase in specificity, and decrease in sensitivity. It also increases false negatives, this part. Clear? Because see, here my test is negative test. So, and these people are actually diabetes. So these are actually not negatives. So these are false negative. So increasing the threshold increases the false negatives, but increases the specificity. So I hope this part is clear. But in the exam you will not have time to think about all these mathematics and all these graphs. So just remember, increasing the threshold, increase in specificity. Decrease in threshold, decrease in specificity. So you can remember like this. Okay. So threshold goes with specificity but opposite of sensitivity. I have just summarized it here. So low cutoff means if you lower the cutoff, it will decrease the specificity. Cutoff and specificity go hand in hand, but it will increase the sensitivity. High cutoff, high specificity. So just remember this is important. So if you take the midpoint cutoff, this midpoint cutoff, it will maximize the combined specificity and sensitivity. So if you want a test which has combined maximum specificity and sensitivity, you will take a midpoint cutoff. Okay, so midpoint cutoff maximizes sensitivity and specificity. And greater the overlap, decreases the combined sensitivity and specificity. Okay, So more the overlap, lesser the combined sensitivity and specificity. Okay, I hope this is clear. Lesser combined sensitivity and specificity because there is a greater overlap, and greater combined sensitivity and specificity because there is minimal overlap. I hope this is clear. So once more, sensitivity and specificity are intrinsic characteristic of the test and doesn't depend on the prevalence of the disease. Okay, likelihood ratio also are the intrinsic characteristic of the test. Only thing that changes with prevalence are positive predictive value and negative predictive value. We will discuss this in some other video. So this is just from my end. So thanks a lot. I will see you in the next video. Thanks.